Good morning, everyone. So I am going to be presenting a section M to you folks, and you may want to use your handouts. I just want to remind you in terms of those that were contained in your folders when we talk about the case studies, so that you can review those case studies. You'll have the opportunity to practice coding the case study items that we have presented to you. And in order to code them, you may want to refer back to your case studies that are in print. I will be reading them from the screen. So let's get started. So potential and actual patient medication errors are prevalent among post-acute care settings and often occur during the transitions in care. So, and medication errors can lead to medication-related adverse reactions, emergency department visits, rehospitalizations, and of course this affects patients' health, safety, and quality of life. So the drug regimen review quality measure is intended to improve patient safety in post-acute care facilities by identifying and addressing potential and actual clinically significant medication issues at the time of patient's admission and throughout the patient's stay. So we've given you a list of acronyms that we'll be using through the presentation, and these also are listed in a sheet that you have received in your packet, so I won't go through each one of these, but they are here for your reference. They are numerous. So first we're going to define the new section N, medications. We'll explain the intent of section N, and we'll explain the new items added to the long-term care continuity assessment record and evaluation, the care data set version 4, and the inpatient rehabilitation facility patient assessment instrument known as the IRF-PAI. This will be in version 2. We'll be discussing the coding instructions for each of these items. There are 3, and provide practice codings, as I mentioned, for the scenarios. And then finally, we'll explain how the DRR quality measure is calculated. So your objectives will be to state the intent of section N, and you'll be able to, after this presentation, articulate the purpose of the new items and also the coding options that are available. Also, applying coding instructions accurately. You'll be able to do that through coding practice scenarios that we go through and the case study. Also be describing new DRR quality measures. So again, this is in the LTAC care data set version 4 and IRF-PAI version 2. So the formal title of this quality process measure is Drug Regimen Review Conducted with Follow-up for Identified Issues. The DRR is an assessment-based cross-setting process quality measure, and it was adopted to meet the requirements of the IMPACT Act and the domain specifically of medication reconciliation. The data collection will begin July 1st, 2018 for the LTACs. October 1st, 2018, the IRFs will begin. The data is already being collected with the home health folks, and they've been collecting since January of 2017. Okay, so there are 2 DRR items that you'll complete at admission, and we'll go through all the terms that are used in these items in a bit. The drug regimen review admission data elements require that you document whether the PAC providers conducted a drug regimen review upon the patient's admission and whether clinically significant medication issues were addressed in a timely manner when identified. So you can see the 2 items at the top. They're N2001 and N2003, each titled differently, drug regimen review and then medication follow-up. So this will be in your admission assessment. For the discharge assessment, you will find that the DRR has a single item, N2005, and the data element is to document whether PAC providers conducted a drug regimen review upon patient admission and whether clinically significant medication issues were identified and addressed in a timely manner throughout the patient's stay. This discharge item includes the entire stay, so it's admission through the discharge. And this is what it'll look like on your instrument. So let's go through some definitions. So drug regimen review in post-acute care is generally considered to include these two elements: medication reconciliation, which is a review of all medication a patient is currently using, and drug regimen review, which is a review of the drug regimen that the patient is to comply with, to identify and, if possible, prevent clinically significant medication issues. So what medications are included for the DRR? The DRR includes all medications. So by this we mean prescribed and over-the-counter. We also are including nutritional supplements, vitamins, and homeopathic and herbal products. So, and we also are considering the routes in which these are all administered, and they include oral, topical, inhalant, injection, sublingual, parenteral, and by infusion. So this also includes TPN, total parenteral nutrition, and oxygen. However, although we say that all medications are included, the measure only identifies potential or clinically significant medication issues that are related to these. So, what is meant by potential or clinically significant medication issues? A potential or actual issue in the clinician's professional judgment warrants physician or physician designee communication and completion of prescribed recommended actions by midnight of the next calendar day at the latest. So it has to have reached that critical decision point by you that the actual or potential issue warrants that timely decision of communication and action. A potential or actually clinically significant medication issue may include, but they are not limited to, medication prescribed despite medication allergies noted in the patient's medical record, or adverse reactions to medication. So this is a medication that you didn't know perhaps the person was allergic to, and upon discovering this with the clinical symptoms and signs that you've noted, becomes a potential clinically significant medication issue. It also includes ineffective drug therapy. Again, it has to reach that critical point. In addition, drug interactions would be an example: serious drug to drug, drug to food, and drug to disease interactions. And these can be very patient specific in terms of the disease and the type of patient that you have, and in regard to what drug you're looking at. This also includes duplicate therapy, for example, a generic name, brand name equivalents, anything such as that is co-prescribed. And then, of course, wrong patient, drug, wrong dose, wrong route, and time errors are also included. And omissions as well, so drugs missing from a prescribed regimen. So when you're doing your comparison, when the patient arrives from an acute care facility, you're looking for what is on their list, what's on your list. You're looking for omissions as well from what the patient may have been taking that you have discovered. Non-adherence, this could be purposeful or accidental. So any circumstance that does not require this immediate action, this is important, any circumstance that does not require this immediate action is not considered a potential or actually clinically significant medication issue for the purpose of this DRR quality measure. So examples of potential or actually clinically significant medication issues can be found in Section N of the quality QRP manual, and that'll be on the CMS website, so you can find more examples there. You'll be determining if very timely action is needed, and that is a key here as to whether this issue has reached the potential clinically significant medication issue level. We know you'd like to hear more examples, so we have written more in those manuals, so you will find more in your manuals on that website. So what do we mean by contact with a physician or physician designee? By that we mean a two-way communication is essential in order to meet the requirements of this measure. You need to communicate and convey this information to the physician or physician designee, and you also need to have received a response from the physician or physician designee so that you can address the issues per their recommendations. So it's a two-way communication. So that's what we're talking about when we say communication. And then example of communication methods, what communication methods do you use? Are they on this list? In person, telephone, voicemail, electronic means, fax, and any other means that appropriately conveys the patient, the message of the patient's status. So so that communication can be direct or indirect. So direct, we mean by that to and from the physician or physician's designee. Indirectly, that could be through the physician's office, through their staff, on behalf of the physician or physician designee. This is all in accordance with practices. So how is a physician designee defined? How can you find this out? So providers like you have asked questions such as this, and so we'd like to provide you more information about this. So the role of a physician designee is defined by federal and state licensure regulations. It may be different for some of you in different states. So we can't give you a blanket statement other than that this is following your federal and state licensure regulations. And please refer to these regulations to determine which clinicians are licensed to act as a physician designee in your state and in your facility. So what do we mean by the term medication follow-up that we use to describe N2003? That's the second admission assessment item. The medication follow-up is that process of contacting the physician or physician designee, that two-way communication, to communicate that identified potential or clinically significant medication issue, and to address all physician or physician designee prescribed or recommended actions by midnight of the next calendar day. Now remember, those actions, recommendations, are to be followed per the physician or physician designee's instructions. So some of them may be recommended to be done by midnight of the next calendar day, but some of them may be recommended to do after midnight of the next calendar day. So think about that in terms of, and we'll have options in terms of coding and instructions on that later. Okay, so we've got some coding guidance here. Where are you going to find the information essential to code these items? You'll find these, of course, in the medical record, and you may have electronic health records, electronic medical records, or you may have a combination of that along with your paper medical forms, as well as transferred from those forms that are transferred from the acute care hospital, the medication list, the MAR, home medication list as well, and then clinical communication notes, including your pharmacy, your clinicians, such as the nurses, physician designee, and other applicable clinicians' notes. And further, you would find them in the acute care hospital discharge summary, of course, and then the discharge instructions. So discussions that you may have may include with the acute care hospital. That's information that's vital to you in terms of this measure, as well as the other staff and clinicians responsible for completing the drug regimen review. And then, of course, patients and their family also can be resources for you. Your facility may decide a specific or central means of gathering all of this information to make it efficient to locate for the relevant coding for this measure. So medical records and data should reflect the coding of the DRR items. It's important that the data that you collect on the LTAC care dataset and also the IRF-PAI is consistent with the information that is reported in the patient's medical records. So those two have to gel. You have to have evidence of what you coded by the nature of the notes that you have, the records that you've collected, and that's true with any of our work here in terms of what we place on these assessments. You have to have your documentation reflect your coding. So who can code the DRR items? CMS does not provide guidance on who can or cannot code the DRR items. We ask you to please refer to your facility, federal, state, or policies and procedures to determine which of your staff members can complete a DRR. So, of course, each facility will determine their own policies and procedures for completing assessments. And then each facility provides patient care, of course, according to your unique populations and characteristics and standards. So we have here the two items for the admission assessment seen on the left-hand side of your screen here, and also the one item that is for the planned or unplanned or expired discharge assessment for the LTAC folks attending here, and then this third item, the N2005, that would be seen for the discharge assessment, on the discharge assessment for the IRF-PAI. So for N2001, what it's asking, that first question is, it identifies if a drug regimen review was conducted upon admission, important, and if the clinician identified any potential or actual clinically significant medication issues. The second question asks you to identify if the facility contacted a physician or physician designee and completed all, very important, all the physician or physician designee's prescribed recommended actions by midnight of the next calendar day in response to all potential or actual clinically significant medication issues. And the discharge item N2005 that identifies if the facility contacted a physician or physician designee and completed all physician or physician designee prescribed recommended actions, again by midnight of the next calendar day, each time a potential clinically significant medication issue was identified throughout the stay. So we mean from admission all the way through discharge. So that last item is comprehensive. It includes what happened at admission. So here's what N2001 will look like in the assessment with 3 choices for coding that we'll review. Your steps for assessment is to complete that DRR upon admission or as close to the actual time of admission as possible to identify any of these clinically significant medication issues. And of course, reviewing the records that we talked about, all those references, resources that we talked about, so that you can determine if there was a DRR conducted. So remember, you will be very familiar with what a potential clinically significant medication issue is. We just reviewed examples. You can also review the ones that are in the manual as well. So for coding instructions, for N2001, it asks, did a complete DRR identify potential clinically significant medication issues? Your Train the Trainer protocol may include sharing this detailed information we provided here and from the manual that includes more coding examples per code. We will also be practicing during the presentation and coding each one of these items. So you can see for the first item, code 01 no means no issues were found during the review. If the DRR was conducted upon admission and no potential or actual clinically significant medication issues were identified, it means there were no issues found. Code 1, yes, issues found during the review if the DRR was conducted upon admission, and of course, if there were those issues that were found. Code 9, which is NA, patient is not taking medications. If the patient was not taking any medications during the DRR and the DRR was conducted upon admission per the data sources we talked about, there were no medications prescribed for the patient, and the patient was not taking any medications at the time of the assessment. That's the only reason why you would use the NA. Okay, and then you'll code either yes or no here. For the second admission question, did the facility contact a physician or physician designee by midnight of the next calendar day and complete the prescribed recommended actions in response to the potential clinically significant medication issues? So for the discharge item and 2003, here are the steps for that assessment. Again, you're going to determine whether the following criteria was met for all potential clinically significant medication issues. It's a two-way communication that we talked about between the clinicians and the physician, and was it completed by midnight of the next calendar day? And also, you need to find out if all physician prescribed recommended actions were completed as they had prescribed by midnight of the next calendar day. Okay, so for the N2003, you'll be coding 0 no or 1 yes, and no is if all identified potential clinic or actual clinically significant medication issues were not completed by midnight of the next calendar day. And code 1 yes for the two-way communication was completed and the prescribed recommended actions occurred by midnight of the next calendar day after the issues were identified. So if a clinician did not communicate all identified clinically significant medication issues to the physician or physician designee until after midnight of the next calendar day, you would choose code 09. Another example would be if a clinician communicated all identified clinically significant medication issues to the physician by midnight of the next calendar day, but the clinician did not receive a response by the physician or the physician designee to communicate the prescribed recommended actions until after midnight of the next calendar day, then again you would code 0 no. So if the drug regimen review is not completed upon admission, then N2001 and 2003 are coded as a dash. A dash is a valid response in this case, but CMS expects dashes to be rare occurrences. So here's what the codes are for N2005. Note, thoroughly instructing your staff on the use of each code will ensure that each code will be used correctly. Again, the same steps apply. You're going to be reviewing the patient's medical documentation, identifying all potential actual clinically significant medication issues that were identified from admission or upon admission all the way through the patient's discharge. So that is that comprehensive N2005. You'll also be determining if both criterias were met for all of the potential or actual clinically significant medication issues that were identified upon admission, again, or any time throughout the stay, admission through discharge. Did that two-way communication occur between the clinicians and the physician? Was it completed by midnight of the next calendar day? And were all of those directives, recommended actions, the prescribed actions, were they all completed by midnight of the next calendar day? So your coding instructions and your codes for N2005 will be 1, no. If all clinically significant medication issues were identified at admission or any time throughout the patient's stay, admission through discharge, were not addressed. So in this case, you're saying no if they were not addressed by midnight of next calendar day. And for code 1, yes, you will use that if all of the clinically significant medication issues upon admission or any time throughout the stay, admission through discharge, were addressed by midnight of next calendar day. So we've got some examples for you in terms of coding no for N2005. At admission or any time during the patient's stay, the clinician did not communicate all identified potential or actual clinically significant medication issues to the physician until after midnight. So that would be coded no. Okay, at admission or at any time during the patient's stay, the clinician's communication to that physician were identifying all potential or actually significant medication issues, but the physician did not respond until after midnight of the next calendar day. Again, you would code no. And then at admission, or any time during the stay, the clinician did not complete all of those recommended prescribed actions for all of the identified issues. Again, if that happens, that's a no. An example of a yes would be at admission and any time throughout the patient's stay, the clinicians contacted every time that physician for all of the potential clinically significant medication issues. So they did that, and then the physician communicated to the clinicians that no actions were necessary. No actions were necessary regarding the reported issues, and all communications took place by midnight of the next calendar day. So that would be an instance where you would say yes, because you were following what that physician said. So for code 9, NA, not applicable, this, again, you want to make sure that you're instructing your staff in terms of what the codes mean. This one's not the same as the code 9 that you saw before. It's not applicable here. It's if there were no potential or actually clinically significant medication issues upon admission or throughout the patient's stay. So there was no issues identified, and the patient was not taking any medications. So that is when you use code 9. Very important to understand this code and practice it. So just to clarify, we talked about N2005, and we talked about upon admission or any time throughout the stay, throughout the discharge. And throughout the stay includes up to the time of the patient discharge. That the drug regimen review is conducted upon admission, and of course clinicians complete those actions recommended by the physician in that timely follow-up and they are completed each time those potential or clinically significant medication issues are identified, and it's throughout the stay. So provider had asked us a question in terms of if a provider coded, what happens if you code N2003 as no on admission, indicating that the required follow-up action did not take place? And is there a way for them, they asked, to code N2005 as yes? And the answer is if N2003 is coded as 03, no, then in accordance with the DRR measure requirements, the item N2005, which includes admission all the way through discharge, must be coded no. So the rationale is that follow-up for all of the identified potential or actually clinically significant medication issues was not completed by midnight of the next calendar day or throughout the stay. Okay, so let's get to these practice scenarios. Now we want to get some feedback from you folks. So if you have that packet handy, you can pull it out, or if you're looking at it on your laptop, this is the time to pull it out so that you can follow along, because after I read this, I'm going to go to the coding and this slide disappears. So if you need some time to reflect on what your coding would be, that will allow you to do that by looking at your packet that says the coding scenarios for section N. Okay, so here we go. First one is going to be the first admission question, N2001, scenario 1. The admitting PAC nurse reviewed and compared the acute care hospital discharge medication orders and the PAC physician admission medication orders for Mrs. W. The nurse interviewed Mrs. W., who confirmed the medications she was taking for her current medical conditions. Upon the nurse's request, the pharmacist reviewed and confirmed the medication orders as appropriate for the patient. As a result of this collected and communicated information, the registered nurse determined that there were no identified or actual clinically significant medication issues. So here are the codes. Let's look at what you have to choose from. 0, no. 1, yes. 9, NA. So no, 0, no is no issues were found during the review. 1 was yes, there were issues found, and 9, NA. So let's see what we have here. We're still working on it. Looks like we're still getting some people on the poll. Okay. And okay, let's go ahead and see how you what the answer was. And it was no, yes, and it looked like more than 97% of you had said that. So no is the answer. And of course the rationale is, as you heard, that the nurse reviewed and compared the patient's medication records from the acute care hospital, and everybody was on board with what was on there, and the RN determined that there were no potential or actually clinically significant medication issues, right? So that was an easy one. So let's look at practice scenario 2 about Mr. C. He was admitted in the PAC undergoing mitral valve replacement. The acute care hospital discharge information indicated that Mr. C had a mechanical mitral heart valve and was to continue receiving anticoagulant medication. While completing a review and comparison of the patient's discharge healthcare records from the acute care hospital with the PAC physician's admission medication orders, an RN noted that the admitting physician ordered the patient's anticoagulation medication to be held if the INR was below 1.0. However, the physician's admission note indicated that the desired therapeutic INR parameters for Mr. C was in fact 2.5 to 3.5. The RN questioned the INR level listed on the admitting physician order and based on the therapeutic parameters of 2.5 to 3.5 documented in the physician's admission note. This prompted the RN to call the physician immediately to address the issue. So, how would you code, did a complete drug regimen review identify potential clinically significant medication issues? Would you say no issues were found during the review? Or would you say, 1, yes, issues were found during the review, or 9, NA, patients not taking any medications? So how are you going to answer this one? A resounding, looks like 97, 98% of you are saying yes. Let's see what the actual answer is. And it is, yes, of course. The issues were found during the review. And we understood, I think, this one pretty thoroughly, that the nurse reviewed, compared the records from acute versus the hospitals. That's what you do when the patient comes in. And the discrepancy was identified in terms of the INR level for this patient being discrepant from the PAC's standard therapeutic range. And of course, that would be the reason for this, having been coded as you all did. And let's go to scenario 3 then. So let's see what happens with Mr. B here. So this is N2003. This is the second question for admission, okay? So you're going to be answering N2003. Mr. B was admitted to post-acute care with an active diagnosis of pneumonia and AFib. The acute care facility medication record indicated that the patient was on a 7-day course of antibiotics, and the patient had 3 remaining days of this treatment plan. The PAC pharmacist reviewing the discharge record from the acute care facility and the PAC admission medication orders noted that the patient had an order for an anticoagulant medication that required INR monitoring as well as the antibiotic. On the day of admission, the PAC pharmacist contacted the PAC physician caring for Mr. B and communicated a concern about the potential increase in the patient's INR with this combination of medications, which placed the patient at a greater risk for bleeding. The PAC physician provided orders for laboratory testing so that the patient's INR levels would be monitored over the next 3 days, starting that day. However, the nurse did not request the first INR laboratory test until after midnight of the next calendar day. Okay? So in this case, we're answering, did the complete drug DRR identify potential clinically significant medication issues? We're going to first do the first segment of this, sorry, that's was there a potential issue identified? For N2001, was a potential issue identified? And of course, we have the answer is 100% yes. And you are correct. There were issues that were found. Let's see what happened then. Once they were found, let's see what happens next. For N2003, did the facility contact a physician or physician? Can you? Whoops, okay. Well, we asked, did the facility contact a physician or physician designee by minute of the next calendar day and complete the prescribed recommended actions? Did they do that by that timeline? 0 was no, 1 was yes. Let's see what happens. How did you poll for this? Okay, no. All right. And that is, in fact, the answer, no. Great. Okay, so for this 2-part coding, you were absolutely correct. Yes was the answer for N2001, and no was the answer for 2003. The PAC staff did not complete to the extent possible the physician prescribed actions, right? There was specific actions that he prescribed, and they did not do it in a timely fashion. So that it's because we're right in the middle of this and we do want your questions, it's very important. Can you write those down, and then we will absolutely address that afterwards, just so that we can continue, and because people wouldn't be able to hear your question, okay? But we do encourage questions, and please write them in, and you have that venue to do that. Okay, so we're going to scenario 4, okay? And this is about Mrs. S., who was admitted to the post-acute care from the acute care hospital, and during the admitting nurse's review of the patient's acute care facility discharge records, it was noted that the patient had been prescribed metformin. However, admission labs indicated the patient had a serum creatinine of 2.4, consistent with renal insufficiency. The PAC admitting nurse contacted the PAC physician designee to ask if this drug would be contraindicated with the patient's current serum creatinine level. 3 hours after the patient's admission to the post-acute care, the PAC physician designee provided orders to discontinue the metformin and start the patient on a short-acting sulfonylurea for ongoing diabetes management. These medication changes were implemented within the hour. Okay, so now you have all the information for N2001 and N2003. So let's look at N2001. Did a complete drug regimen review, identified potential clinically significant medication issues. 0, no, 1, yes, 9, NA. And it looks like people are saying yes. Okay, so let's see what the actual answer is. Yes. Okay, and next, let's go to N2003. Did the facility contact a physician or physician designee by midnight of the next calendar day and complete the prescribed recommended actions in response to the identified potential clinically significant medication issue? Is it 0, no, or 1, yes? Let's see how you're polling. And a resounding yes. Excellent. Let's see. And we do see that that is yes. And yes, in these scenarios, both were yes. It was identified and it was completed by midnight of next calendar day. And that good communication occurred between the nurse and the physician designee who prescribed it. In this case, the medication had been ordered, it was contraindicated for the patient, but that two-way communication, that's essential and also important for you folks to document that it happens so that you can code these and know which codes to use. And so in this case, discontinuing the contraindicated medication happened, and it happened timely. So now we have practice scenario 5, and this is going to be N2005. So in these scenarios, we're going to have you code N2001, N2003, and N2005, just so that you're practicing. Obviously at discharge, you would only be coding N2005 because at admission, N2001 and 3 had been done. But in this case, we want you to be able to practice. So here's the case study so that you can apply those 3 items for coding practice. At discharge from the PAC, the discharging licensed clinician reviewed Ms. T's medical record, which included admission through her entire stay at the PAC. The clinician noted that a clinically significant medication issue was documented during admission assessment. At admission, Ms. T was taking 2 antibiotics, an antibiotic prescribed during a recent acute care hospital stay that the PAC physician had included in her PAC medication orders, and a second antibiotic prescribed by the physician upon admission that is known for drug-induced nephrotoxicity. Ms. T has renal disease. So, Ms. T's medical record further indicated that a PAC nurse had attempted to contact the assigned PAC physician several times about this clinically significant medication issue. After midnight of the second calendar day, the PAC physician communicated to the nurse via a telephone order to administer a newly prescribed antibiotic in addition to the previously prescribed antibiotic. The nurse implemented the physician's orders. Upon further review, Ms. T's medical records, the discharging nurse determined that no additional clinically significant medication issues had been recorded throughout the remainder of Mrs. T's stay. So, think about this. You're going through each one of the items. We're going to start with N2001. This is at admission. Did a complete drug regimen review identify potential clinically significant medication issues? Is the answer 0, no, no issues were found during the review? Or 1, yes, issues were found during the review? Or 9, NA, or dash? What is your answer? So this is the first one, and you're saying yes. We've got over 98% are saying yes. Let's see what the answer is. Yes, in fact, it is true. Okay, so now we're looking at N2003, the second one, the follow-up question at admission. Did the facility contact a physician or physician designee by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential clinically significant medication issue? Is it 0, no, or is it 1, yes, or a dash? What is the answer for this one? Okay. We have 92% saying no, 93, and the answer is no. Okay, and so now, knowing this, we're going to go to N2005, and we're going to answer N2005 on the discharge assessment. Did the facility contact and complete physician or physician designee prescribe recommended actions by midnight of the next calendar day each time the potential clinically significant medication issues were identified since the admission? Is it going to be 0, no, 1, yes, or 9, NA? How are you going to answer this one? Okay. The no's win at 92%. We've got 4% for 1. Okay, and the answer is no. So let's look at the coding and then the rationale. So N2001 was yes, there were issues found. N2003 we said no, because not all of those issues were completed by midnight of the next calendar day. And 2005, and we said no. Okay, so the rationale is that coding of N2005 includes all clinically significant medication issues. This includes everything from the admission through the discharge. And in this case, we look at that they were or were not communicated to the physician with prescribed medication recommended actions completed by midnight of the next calendar day. In this scenario, though, although no potential or actual clinically significant medication issues were identified by the nurse during the remainder of the stay, and this is important, the notification of the issues identified at admission, despite repeated communications attempted by the nurse, were not addressed by the physician by midnight of the next calendar day. So at discharge, the license, so that is our scenario 5. Okay. So for the next scenario we're looking at is, again, going to be this comprehensive N2005. And let's look at this. So at discharge, the licensed clinician completing a review of Mrs. K's medical records identified and noted 2 clinically significant medication issues during the patient's stay. Patient record included the order to hold the medication Mrs. K was receiving for deep vein thrombosis prophylaxis. Based on the patient's clinical status, the RN determined that the physician needed urgent notification. The day after the observed symptoms were identified, the physician notification occurred. The PAC physician provided an order to resume the medication, which was carried out by the nurse within an hour. And in addition, the licensed clinician identified a clinically significant medication issue that occurred during the admission assessment period, and the physician had been contacted on the same day, and both medication issues identified during the patient's stay were communicated and addressed by midnight of the next calendar day. There were no additional clinically significant medication issues during the remainder of the PAC stay. So let's start with N2001. Was a complete DRR identifying potential clinically significant medication issues? And the answer would be no, or yes, or NA. Which one is it? Okay, yes. And then let's see what the answer actually is. And yes, of course it is yes. And for N2003, this is the follow-up question at admission. Did the facility contact a physician by midnight of next calendar day and complete the prescribed recommended actions? 0, no. 1, yes. And the yeses have it here. Okay, and let's find out. It was yes. And then finally for N2005, again, we're looking at from admission through discharge. Prescribed recommended actions by midnight next calendar day. Each time, potential clinically significant medication issues identified since the admission. 0, no. 1, yes. 9, NA. What's your answer? Okay, the yeses have it again. Let's go look at the issue. Okay, so yes, this was yes all the way. Everything had been coded correctly. So let's take a look at the measure in terms of how we're going to be reporting this in terms of a percentage of patient stays in which the drug regimen review is conducted at the time of admission. So this is going to be related to how we calculate the measure. We look at it through, was the DRR conducted at the time of admission, and we also look at, was there timely follow-up with a physician that occurred each time the potential actually clinically significant medication was identified throughout the patient's stay. So here's what it looks like. So to calculate the percentage of patients that successfully met the DRR measure criteria, we first set up a fraction. So you can see that we have the numerator on the top and the denominator on the bottom. We divide the number that would appear in the numerator by the denominator's number. So let's work our way from the bottom up. The denominator represents the number of patient stays during the LTAC or IRF reporting period, but only those patient stays for the patients who qualify to be assessed by the LTAC care data set or IRF-PAI. You folks have distinctions in terms of that criteria. That's your denominator. Your numerator will be all of those qualifying patient stays that you had included in the denominator, in which the criteria has to be met of no potential or actually clinically significant medication issues that were found during the review, or potential or actual clinically significant medication issues were found during the review and the physician was contacted and prescribed recommended actions, and they were all completed by midnight of the next calendar day, or the patient was not taking any medications. Okay? So for this measure, there's no denominator exclusions, and this measure is not risk adjusted or stratified. So we have gone through each of these items, the N2001, 3, and 5. If a dash is entered for any of these 3 items, the patient's stay will not be included in the numerator count. The patient's stay will be included in the denominator count instead. So a dash value is a valid response for this item. However, CMS expects the dash use to be a rare occurrence. If the patient was discharged before the DRR, admission assessment items were completed, then N2001 and N2003 are coded with a dash. So in summary, the section N is new to each of your assessment instruments, the LTAC Care data set. It'll be in version 4. For IRF-PAI, it's in version 2, and it includes these 3 items we've gone through. This measure, again, assesses whether providers conducted that DRR upon the patient's admission and upon the patient's stay, and whether any potential or actual clinically significant medication issues were identified, and most importantly, addressed in a timely manner. So, very important, this measure has a lot of features in it that we want you to consider in terms of your action plan. And so by getting all this information, by going through the manual and through section N, you'll be able to again come up with more information to apply to your action plan. So first of all, you want to determine that you have the appropriate healthcare personnel who will collect and enter the DRR information from that medical record. Or all of the resources that you have. You want to identify your staff who will need to be trained and coded on the DRR, and we've given you lots of resources here. And also then it's extremely important to develop that process and protocol to use in tracking clinical data collection. So tracking documentation so that you can code the DRR. So you want to be able to identify how to do that. Some providers have discussed various methods they intend to use to record, to track, and apply relevant data to code these items. Some providers have plans to use software programs to track and use the DRR data, while others plan to just integrate the data elements into their existing EHR system. So this is something that's important for you folks to consider when planning. And of course, reviewing section N, the intent, the rationale, steps for assessment that we've completed, and then reviewing the steps for evaluation and the coding tips. Again, there's more information, more resources in the manual that we've put together for you folks, and practice coding a variety of scenarios. We've given you some here, and you can take some of your very own patients and present those for your scenarios. So we want you to write your questions down. We have another presenter coming up next, but we do want your questions. Do write them in to the web that we have provided for you, which you used for polling. So thank you so much.